Right, so I'd like to give the floor to Jean-Yves and Jean-Patrick for this panel session on spine.
We'll start this spine session right away with Jean-Yves, who is going to talk about sagittal balance in aging patients. So, red thread this year is the aging patients. It's very interesting for those people who are in spine surgery and who are also interested in lower limb surgery, because all the adjustment criteria are based on simple anatomical concepts with criteria which most likely do not meet and fit with the criteria we have with our aging patients. This is a panel of patients we have to treat. As you see, there's a great diversity in the examples of sagittal balance that we have. What do we know about sagittal balance? And our knowledge is rather limited because most of the studies, in order to come up with normal values, were made on younger asymptomatic patients. And what happens when there is an aging of the trunk in the standing position? Well, all the criteria that sometimes lead to a spine correction surgery, which could be very aggressive, are based on the standing position, while the transfer from standing to sitting is not well known. So what do we know about the standing sagittal balance? In the standing position, we call it the C-set plumb line problem, which will go either to the front or in the back, and lordosis for standard patients, we would say. This is a patient who had surgery versus, and you see this plumb line, which is behind the femoral heads. And for a long time, it was pretty much intuitive. And with the development of full body imaging, we've realized that some patients had unbalances such as this one. With a lower limb response, that surgery could correct by simply changing the sagittal balance in the spine, which would change the response of the lower limbs. So our knowledge has been rather patchy, let's say, up to the time when several surgeons started to focus on the lower limb impact of sagittal balance. And Le GECO in 2019 has shown that when there is an impaired sagittal balance, this does have an impact in the lower limbs. And that's a problem with our aged patients because it's not a spine disease as such. It is the disease also of the lower limbs, because in these patients, you can have either a knee implant or a hip implant. So how do we analyze these situations? Well, unfortunately, we only look at either the knee or the hip, quite rightly so, because sometimes there is a disease that needs to be treated with an implant, but we do not take into account the overall sagittal balance. So we use the SFA, the angle also between the pelvis and the femur axis, which is an angle which is quite often used by spine surgeon, or the tilt, the femoral sagittal tilt. And with today imaging technique, we have other solutions, a dynamic image, which helps us to see how the patient will transfer from the sitting to standing position. And there is a loss of ability here, which can be inducing a compensation feminism. So there are 3 types of mechanisms to be looked at and to be analyzed in a thorough way on those patients. The first thing is the compensation of the unbalance through a retroversion of the pelvis. That is a hip extension. So the pelvis, where the sacrum is too vertical, they do not have a hip flexum. It's a hyper extension of the hip. And this is something that hip specialists had some difficulties to understand. It's not a flexum. It's a hyper extension of the hip. The other compensation mechanism is the knee flexion, and things that we do not really know, that is the ankle response. And I'm not a specialized in ankle or foot surgery, but it's interesting to see also this part of the body. The spine specialist will focus on SVA, that is the plumb line, as I explained, and will determine it in the following way. If there is what we call in France the anteversion of the pelvis, or when we consider the general posture of the pelvis, we check whether there is an extension or not. And very often, but not always, our aged patient will show a pelvic extension. The problem is that not all the patients have the same width. There are 3 patients here. One has a narrow pelvis, the other one has a normal or standard pelvis, and the other one has a very broad one. This is what we call the pelvic incidence angle, which should be between 45, 55 degrees. But then the message went through, and hip surgeons have started also to consider the sacrum slope to try and see whether it was leading to a normal or an abnormal pelvic tilt. Rossoli has demonstrated, and that's the French school of thought for many years, that there are 4 types of spines. But what is not shown here is the hip. While it's very interesting because some patients will have a narrow pelvis with a low pelvic incidence, another will have a high pelvic incidence. You might say, well, this is of no interest for us, pelvic surgeon. But no, it is interesting because those who have a small pelvic incidence have a very particular spine geometry with no retroversion of the pelvis. These patients will not have a compensation capacity for this sagittal imbalance by changing their pelvic tilt. Here, for this other patient with a low pelvic incidence, very low potential for pelvic retroversion, so very low compensation capacity. So the message here is that we should focus on those patients with a low pelvic incidence below 45 degrees. When it's a higher pelvic incidence, no problem, and we've recently published a paper on this, there is a compensation. So beware of aging patient with a low pelvic incidence. What happens when you move from standing to sitting position, where there is a retroversion of the pelvis or this extension, as you can see on this animated image here. And this is what happens with a patient with an implant. He's standing up, proper lordosis, he sits down, and this is what you see with the pelvic retroversion. We have already explained the acetabulum orientation in the previous GECO conferences, but it's not our purpose here. But in aging patients, some will use their spine and their hip when moving from standing to sitting. Here, the sacrum slope is 45 degrees with a pelvic tilt, which will be the focus of my presentation later. The vertical line between the femoral head and the center of the pelvis, and has a high pelvic incidence, 68 degrees. No problem with sitting. The slope will decrease 25 degrees, and he will rely on his spine. But here, this patient, for any reason, will pretty much rely on the spine. The slope variation is significant, as well as the pelvic tilt, and he's not able to flex his hip for any reason. So in aging patients, you have to consider the pelvic incidence angle and on the profile image whether there will be rather a hip or a spine user. And this will have an impact on implant instability, which is quite common in hip surgery or spine surgery. What I would like to emphasize at the end of this presentation is the overall view we have of the patient. There is no knee degeneration or the hip. There are other degeneration areas in the spine. And now we've started to be interested, and that's a new focus in our research, of what we call the overall tilt or the global tilt, the vertical line between S5 and the line that goes up to the thoracic vertebra. It's the important vertebra here. So, 3 parameters: global tilt T9, pelvic tilt in black, and the sacrum slope. And I will deduct the latter. And we'll check on the next patient, so the global tilt, as we call it, at T9, and how the hip and the pelvis will respond. The pelvis is part of the spine, in our opinion, because it's important in the movement. So gravity line, which is described in young patients in a typical way with the plumb line, which will be behind the femoral head, doesn't work with aging patients. There are 3 types of orientation. You have the grade 1, where the line is in the back. Others where it's right in the middle of the hip, while for the others it is anterior. And here is this patient, pre-op, post-op. You see that the sagittal balance was improved. The gravity line is here, very interestingly, when he's seated. Another example here, where we see patients who are grade 3 with an imbalance. And these patients seem to be more favorable because the line is in the back of the femoral head, behind the femoral head. And it might be important for the stability of hip implant. We went through a series of cases, a patient standing and then sitting. You see that the line changes completely between the 2 positions. Another case with a knee implant, grade 3, because the line is in the front when he's standing and in the back when seated. So it's a very interesting parameter. This is an aneurysmorphing, and in this patient, we've changed, thanks to the implant, the way the patient would sit. This changes the gravity line in an anterior way. It has a lever effect, which may account for a dislocation of a hip. If we take into account this line, maybe we can find a cause for these dislocations. Here, a good case. The hip has become the pivot for the response, and here the line is a posterior line. So we'll then focus on patients to identify those who are hip user versus spine users with our plumb line, the pelvic tilt, the pelvic response, and the response of the upper spine. And we reviewed a few cases. Now this one here is standing, is a grade 3, not that good, and is grade 2 when seated with the plumb line going through the femoral heads. The change is that there is a tilting of the pelvis, but there's no change in the spine position, which remains rigid while there is a tilting of the hip. So it's a hip user. A spine user with a pelvic tilt. We've preached the gospel to people on the pelvic rotation for the transfer to sitting position. We forgot the upper spine, which is important for a surgeon specialized in the spine, but might also be important for hip surgeon. Here, another case, a grade 3 and 2. He's a hip user. He's also a spine user, but in the pelvic side, not the upper part of the spine, because this yellow angle doesn't change. Same here. It changes, but not the upper part of the pelvis. Now, this one is a favorable case, using the hip and the spine with a pelvic tilt, and the GT angle also in the upper part of the spine has changed. And another example where we can definitely see that he's not using his hip to sit down and compensates with a tilt of the spine. If I go for a spine arthrodesis, I will probably have a disaster. Here, the spine is completely frozen, and he's mainly a hip user. This is the gravity line for this one, rather favorable, and you see that he doesn't use his spine when sitting down. Pre-op here, where the tilt will change a lot between the standing and sitting position, and after surgery, the upper part of the spine didn't change. So what are the key take-home message? So we have to completely change our paradigm for aging patients. We do understand pelvic retroversion, knee flexion, and the ankle extension, even though it's not thoroughly studied. When we have patients who are involving some potential risk, we have to know what is their gravity line and whether their pelvis is in extension or whether the sacrum is in a vertical or almost horizontal position. And also beware of low pelvic incidence, because there is little potential for pelvic retroversion. And also, that's because we need an extension reserve, let's say, for the retroversion of the pelvis for the patients to sit down. Next key message. In aging patients, their posture will change a lot when it comes to their plumb line, as we call it. This one is very anterior, so beware of that, because their pelvic tilt may induce some instabilities. Last take-home message, we have to identify those who are hip users versus those who do not use their spine at all. If we go for an arthrodesis, we won't change anything to these mechanisms. But for those patients who are using both their hip and the spine, some will be using both, that is the pelvic tilt, and they will be a GT user. And an arthrodesis in this patient may result in a disaster. So these are the few take-home messages that are gradually emerging after the analysis of a large series of aging patients. Beware of poor pelvic incidence. Don't consider only the pelvis, but also you have to consider the upper spine. Thank you. Thank you, Jean-Yves, for this excellent presentation, which is an excellent summary for the knowledge of hip and spine surgeons. So when we would use to perform an arthrodesis in the spine, and a sitting and standing EOS is absolutely key. When it's a grade 3, a typical aged patient, and that there is no extension reserve, if you do an osteotomy, you may have a gain of 30 degrees, but you won't solve the problem. So what would you suggest in such cases? That's a big issue, because we are the victims of the what I call the ayatollahs of sagittal balances standing. So we considered that all patients needed a sagittal balance when standing. So when their pelvic incidence is too low, they don't have any extension capacity. So it results in a disaster. So a hyperlordosis, an overcorrection in aging patient doesn't work. And we've observed this because we published in GOA a few years back a series of patients with arthrodesis and hip implant. There were no dislocations, and Americans started to publish with 14% dislocation rates. But when you look at their series, they didn't show what was the pelvic incidence and what was the overall balance of the patient. They just talk about an unbalance and the length of the arthrodesis. When we reviewed our cases, we realized we had, a hypercorrection in lordosis. So there's a new instability of the hip, a secondary imbalance which was induced because the devices for the spine were too powerful, let's say. Questions for hip surgeons? No microphone. When you have a coxarthrosis and a spine arthrosis, the problem is that you have to know whether you have to switch to dual mobility. But it won't solve everything, but you can have the case of a patient with a low incidence, pelvic incidence, and arthrodesis. It seems that if there is a flexion, but there's already a hyperextension, and that is a problem. And for a hip surgeon, we need to convey them this message of a false flexum. This is something that I learned when I was a resident in my internship. We didn't know exactly what it was because we didn't have the imaging that we have today, but that is truly a problem. Don't you think that we should have a less interversion of the cups when there is an interversion of the pelvis? Well, it's more complex than that. Today, the Americans have started to describe magical formulas to position the cup as a function of the sagittal balance. But there is also the front position, and the pelvis rotation is very important. It all seems that as if that it's only the frontal plane. But when you look at the patient's x-rays, quite often there is an asymmetry of the iliac crests, but only acting on the sagittal plane can result in a very unpleasant problems because of the rotation of the pelvis. Second, we are not able to know exactly how the patient is going to cope and adapt himself after that. That was a great surprise to us. This straight plumb line that were grade 3 when sitting became grade 1. We are unable to predict what's going to happen. And another interesting thing is that when the sagittal balance is assessed, when the patient is standing, it says that it is a maximum of extension. But when they're seated, you realize that you still have a retroversion of the pelvis because we do not take into account the muscle action, and that is a problem. There is still a lot to be learned in this area.